chemotherapy. Please join me in welcoming Dr. Jean-Marc Classe from the Institut de Cancérologie de l'Ouest at Nantes University. My French accent is not very good, I apologize, in France to present the findings.
Okay, thanks a lot for this kind invitation. It's a pleasure to present the CARACO trial, the results of the CARACO trial. When a patient is treated for an advanced ovarian cancer, and when we found a bulky retroperitoneal lymph node, we need to remove them. But in case of no suspicious lymph node, the question is it possible to avoid the removal of the lymph node? The treatment, surgical treatment of patients with an advanced ovarian cancer is primary surgery, complete surgery, and if not feasible, is interval surgery. The question of the omission of lymphadenectomy in case of no suspicious lymph node is the objective of the LION trial previously published in the New England, and he found no interest in performing a lymphadenectomy in this kind of patient, but with primary surgery. And the CARACO trial is aimed at performing the omission of lymphadenectomy in the case of interval surgery. So, this is the design of the trial. The epithelial ovarian cancer, FIGO stage 3 or 4, A, no metastasis, no suspicious retroperitoneal lymph nodes, no bulky nodes, optimal surgery achievable, primary or interval surgery, and a residual less than 1 centimeter. The randomization was performed during surgery, and the randomization was surgery with lymphadenectomy against surgery without lymphadenectomy, and every treatment, systemic treatment, before or after surgery was according to the standard of care. A statistical design, the primary end of this superiority trial was progression-free survival, with the objective to show superiority of progression-free survival. We need 335 events, needing 450 patients randomized, with secondary endpoints, overall survival, safety, and surgical outcome. We must say at the beginning that we obtain less inclusion than less events than required because of the publication of the LION trial in the ASCO meeting in 2017. So at the time of this presentation, we need to perform a premature closing of the trial. We obtain less events, 22 events are missing, so 6% of the total event needed. The inclusion criteria, exclusion criteria were very classical. The baseline characteristics and surgical results, it's interesting to see that the surgery to not any residual was very high, 85 to 88%. The rate of lymph node involvement in the lymphadenectomy arm was 43%, and the median duration of surgery in the lymphadenectomy arm was 1 hour more. Concerning the severe morbidity and mortality, we observed a statistically significant higher morbidity in the lymphadenectomy arm, with more transfusion, more re-intervention, more urinary injury, and the mortality was the same between the two arms. And here are the results of the trial. Considering the primary endpoint, the progression-free survival is negative, with a ratio near to 1, 0.92. And considering overall survival, it's also negative. So, in conclusion, the CARACO trial is the only prospectively randomized trial asking the question of the impact of systematic lymphadenectomy in case of neoadjuvant chemotherapy. So adding retroperitoneal lymphadenectomy to complete cytoreductive surgery in primary surgery or after neoadjuvant chemotherapy in patients treated for an advanced ovarian cancer does not improve progression-free survival nor overall survival.
Dr. Michael Lowe, an ASCO expert from the Emory University School of Medicine in Atlanta, Georgia, will now share a few additional comments about the significance of this research.
Congratulations to the CARACO study team for completing this incredibly important study investigating the role of less extensive surgery in patients with advanced ovarian cancer. Their efforts underscore the difficulties of designing and accruing to surgical clinical trials, especially clinical trials in which patients are offered less surgery. And they should be congratulated for their efforts over almost 2 decades in their attempt to answer this important question. This trial shows similar outcomes between patients that received and did not receive more extensive lymph node removal at the time of the removal of their primary ovarian cancer. These findings are consistent with other clinical trials in breast cancer and melanoma that likewise showed similar outcomes for patients that did not undergo removal of clinically normal appearing lymph nodes. Unfortunately, much work needs to be done for these patients to improve overall outcomes, but this study highlights that the focus of these efforts should be on more effective medical therapies. As we continue to seek more patient-centered approaches to cancer care, optimizing surgical technique is crucial to ensuring safe and optimal outcomes for patients. Based on the study, that will mean less invasive surgery for patients with advanced ovarian cancer.
Dr. Lowe, it is very clear that lymph node dissection has significant morbidity. You showed that very clearly. And it's very clear that we should not be doing more surgery than is needed or offers benefit. I would say that compared to the breast and melanoma trials in earlier stage disease, the addition of an axillary lymph node dissection did not benefit, but everybody did well. It's a little bit different in this case, which is advanced ovarian cancer, where neither group did well. So while I think in both cases we've shown more surgery didn't help, it's exactly as Dr. Lowe has said, even in the group that got the lymphadenectomy, we had a very high recurrence and death rate. So focusing in advanced ovarian cancer where the majority already have distant disease, maybe that we can't see, the systemic therapy is what's probably going to have the most impact. So next we'll move on